be talking about digital innovation for COVID-19. So as Professor Conway said, I'm leading digital transformation for the HSE. And we have 5 strands to our strategy, but I'm going to particularly focus on our open innovation strategy and our digital innovation labs. So about HSE digital transformation, it was formed about 1.25 years ago. And what we do basically is act as an enabler and catalyst to drive broad digital transformation across the HSE. We have a 5 to 10 year roadmap actually to transform Ireland's digital health capability. Right now, we'd have to acknowledge that the industry, the health industry is actually about a decade behind other industries in digitalizing. And this is according to research from the OECD. But I think we see this every time we walk into a hospital or even a doctor's surgery, that the advancement of digital in healthcare has been very slow. According to the OECD report, Healthcare in the 21st Century, Ireland is actually quite a ways behind mainstream Europe in terms of adoption of digital in healthcare. So we have an industry that's a decade behind other industries in digitalization, and we have Ireland as a country, we're several years behind the European average. We have a plan to be a European leader in about 5 years, and with a little bit of luck could be a global leader within the next decade. So there are 5 elements to our digital transformation strategy. We have a digital academy similar to the Digital Academy in the UK, but quite a bit broader. We focus on open innovation and working with the ecosystem to transform our healthcare system. We have a set of a digital innovation portfolio, but we've recently announced a set of digital living labs, which I'll talk briefly about. We have a Digital Academy Forum, which is the equivalent of TED Talks for healthcare in Ireland, and we use this for solutionizing and spreading and sharing good ideas. And then, of course, we're digitizing ourselves. We're digitalizing, working with various processes and capabilities to transform them. So since we started 1.25 years ago, we developed a digital transformation strategy, which you can see in front of you. We've created a new master's in digital healthcare. We currently have 50 students on that program. I'll mention it briefly now in a second. We have a portfolio of about 50 projects and solutions and ideas which we're managing through an innovation pipeline. And I'm glad to say that we've been quite successful during the COVID-19 period in getting some of these innovations across the line. We have a digital innovation strategy for the industry, which we call Stay Left, Shift Left. I'll talk about that. And we've held 4 Digital Academy Fora since we've kicked off the function. I wanted to mention the Masters in Digital Health Transformation. Currently, we have 50 students on that, but what is different is that instead of writing a dissertation, the students have to complete a digital change project across the HSE. So right now, we have 21 digital change projects that are happening across the HSE managed out of this master's program. The master's program is quite unique in terms of that it is co-designed and co-delivered by all 8 Irish universities. And Dr. Pam Hussey and Professor Anthony Staines are the DCU representatives on this design activity and delivery activity, and they have recently just delivered their module, and they're also supervising some of the projects. So there's a strong DCU connection to this. Now, we want to talk about open innovation. This is the digital strategy that we use to align the ecosystem that we work with. We call it Stay Left, Shift Left, and it's very simple. But what we found is that the ecosystem is aligning with this strategy, and frequently is coming to us with solutions. Say, here's how we're helping you stay left, shift left. Stay left is about keeping well people well, or if you happen to have a chronic condition, you could be managed best of all from home. Shift left is about moving people as quickly as possible from an acute to a community to a home setting. Every time we find a digital intervention, we're looking for four characteristics. We're looking for a reduction in the cost of care, improvement in the quality of care, improvement in quality of life, and an improvement in the clinician experience. And routinely, we are finding digital solutions that give us a 10x improvement in quality of care, and often a 10x reduction in the cost of care. So when you are doing a transformation, we actually have to transform the industry, not just the HSE. It's important to have an explicit digital innovation strategy, and this is what we have here. Open Innovation 2.0, this is what we call a new mode for digital innovation. And I recently authored a piece in Nature about this methodology, and also published a book called Open Innovation 2.0, the new paradigm for digital innovation. And what we see is there's a new primordial soup, and everybody is innovating together. So universities with startups, with government and policymakers, and with patients involved as well. And the examples I'll share with you are good examples of open innovation. Larry Downes has written an excellent book called Big Bang Disruption, and this happens when the normal adoption cycle for products or services, is really compressed and happens very quickly. And what we have seen is COVID has been a big bang disruptor within the HSE and the broader healthcare system for digital innovation. This is what our innovation pipeline looked like before COVID. We had a lot of ideas in the assessment gate or exploration phase. We had a handful in proof of concept, one in demonstrator, but none adopted. Now, this is what the innovation pipeline looked after the first wave of COVID. Many projects in proof of concept, some in demonstrator, and 6 or 7 had been broadly adopted. Now, typically it takes at least 2 years for a project or a new solution to go through this pipeline from idea to a deployed solution. But using agile methods and, with the precept that necessity is a mother of invention, we managed to get some solutions through the innovation pipeline in 4 to 5 weeks. At the start of the first wave of the pandemic, we opened up the solution portal, and we had many companies and individuals submit ideas. We had more than 100 ideas, and we assessed those, and a couple of those got across the line. One that we're probably most proud of is a remote management solution for COVID-19. So instead of patients being hospitalized if they had mild or moderate COVID symptoms, they were sent home and they were prescribed an app with a pulse oximeter. They were asked to monitor themselves, 2 or 3 times a day. And if their oxygen saturation level dropped below a certain level, 93%, then there was an intervention driven via an automated text message, automated phone call to a clinician. So this has worked very well. At the peak, we had more than 1,000 patients being monitored from home, and this saved tens of thousands of bed nights in our hospital system. So we never got to a situation where we were like Lombardy. I presented this solution as a prototype concept at the IIEA in March, and within 2.5 weeks, we had it being prescribed in different hospitals in the country. And we went from no solution, to more than 30 hospitals and assessment hubs prescribing this solution in 5 weeks. And when I tell you that it normally takes about 2 years to achieve such a solution, you can see how rapid the response was. So we were very pleased with this. Now, I'm very pleased to say that we're extending the use of this solution, and it's not just being used for COVID-19 patients, but it's also being used for patients that have long-term respiratory illnesses such as COPD, pulmonary fibrosis, and cystic fibrosis. Another digital innovation, which was very simple but very impactful, was the distribution of non-contact digital thermometers across the HSE network. So you can see the device on your left, and this reduced the contact between the patient and the nurse, so lowering the risk of contamination. But I mentioned earlier that sometimes we see a 10x cost reduction. In this case, we saw a 5x cost reduction in the total cost of ownership of these devices. We distributed more than 10,000 of these devices across the hospital network, to paramedics, to public health nurses, to acute hospitals, and it's proven a very effective solution. Blue Eye Direct is a technology that we were trialing to give real-time secure broadband or wireless pictures from the scene of an accident back to an emergency hospital. In the first week of the crisis, we repurposed this technology and we used it for secure video calling. And now, of course, Zoom is pervasive and Microsoft Teams, but we made this available within a week and a half of the first wave of the crisis happening. And most of the mental health consultations across the island that are virtual use this technology, as well as St. James's Hospital is using it. And it's very simple in that the patient just needs to click on a link that is sent by text by the clinician to have their appointment. And to date, we've had, I think, 20,000 consultations using this technology. Before the COVID crisis, it wasn't commonplace for GPs to have video consultations with their patients, but now it has become commonplace. We moved very quickly again in the first weeks of the COVID-19 wave 1, and we got 2 providers, Wallola and US Solutions, and within 2 days they had stood up remote patient communication portals for GPs and clinics. And within 48 hours of making these services available, we had more than 600 clinics and doctors on each of these services. And you can see from this curve, we saw very fast adoption when we made the service available at the end of March. Straight away, we got adoption, and it's been running at about 85,000 virtual consultations per month. Interesting to note that GP consultations are about 10 times the volume of hospital outpatient appointments. So the bulk of our care in the primary care, happens actually in primary care settings. A side benefit of this is that the did not attend rates dropped from an average of about 15% to 3%. So this is a very important development moving forward. Another innovation, which wasn't a technical innovation, but was a legislative innovation, was the allowance of electronic prescriptions. Before the COVID crisis, it was possible to send a prescription electronically. That's kind of obvious, but there was no legislative framework to enable this. So I pulled together a meeting, together with the Department of Health of the Irish Pharmacy Union, the Irish College of GPs, and Clanwilliam, who are the big systems provider to GPs. And within 2 meetings, we had clearly decided that we needed to adopt electronic prescription. There was new legislation that was put in place, and again we saw a big bang adoption. So you can see on the curve here the prescribing activity that happened very quickly, and the peak we had close to 2,500 GPs sending prescriptions electronically, and over 2,200 GP or pharmacies dispensing prescriptions. Just to show you again the concept of Big Bang adoption, we went from a volume on the first day of about 80 prescriptions. By the 3rd day, we were up at 21,000 electronic prescriptions. So this has been a feature of COVID-19 Big Bang adoption. Another solution that we developed, and this was developed in Bowman solution with respiratory clinicians from 4 or 5 Dublin teaching hospitals. And at this time, we were seeing images from Lombardy of hospitals being completely overrun. So this solution was developed to help non-respiratory clinicians, help out in A&E and in COVID wards. Thankfully, it wasn't fully needed to be deployed as our COVID wave one sort of tailed off, but we have it deployed in about 6 hospitals, and it's there in the background if wave 2 gets out of hand. A big success story of COVID-19 was the deployment of automated respiration rate management. And this is an example of a technology called RespiraSense that wirelessly transmits respiration rate. And this predicts about 12 hours in advance that a patient is going to deteriorate due to COVID-19 conditions, and means we can intervene earlier. But recording respiration rate has always been problematic. And in our living lab in Beaumont, we found that 80% of the respiration rates manually recorded by nurses were incorrect. This isn't because they're bad nurses, because it's just difficult to accurately manage. But this solution was very helpful in that it reduced the need for interaction between nurses and patients to check their respiration rate, because it was being wirelessly remotely monitored. Now, I want to talk about HSE digital labs. This is something that we announced a couple of weeks ago. I mentioned we have a portfolio of about 50 promising digital technologies and solutions that we're managing. Each of these solutions pass through 4 phases: exploration, pilot, demonstrator, and broad adoption. We talk about living labs, and a living lab is a user-centered open innovation ecosystem or environment. It often happens in a territorial context. It can be in a city or a region, or it can be virtual. In the living lab, we try and integrate concurrent research and innovation processes, and these happen within a public-private people partnership context. So this is a view of the living labs that we announced a couple of weeks ago. They go from Sligo to Cork to Roscommon to Cavan to Wexford. We have a couple in Dublin and a couple of virtual ones. And just some brief examples of these: we're trialing a digital health passport. I'm pretty convinced that we need to move to rapid antigen testing soon. And this passport can actually give a real-time status, whether you are amber, which is medium risk, or if I've just had a rapid antigen test and I'm negative on that, it's changed my status to green. If I have COVID, I have a red status. We demonstrated a live rapid antigen test in our Digital Academy forum a couple of weeks ago, and if you're interested, you can go and check that out. We have that on our webpage, or www.hsedigitaltransformation.ie. One of the things we trialed prior to and during the COVID period was mobile X-ray for nursing homes and private homes. This is a solution that has worked very well. So instead of bringing a patient from their home or a nursing home to a hospital, the X-ray machine is brought to them and has proved very effective. Over 85% of patients didn't need transfers to a hospital because of a fracture. In Tullamore, we have a living lab focused on ultraviolet cleaning. This is a spin out from Trinity College called Icara. It's proving very effective at killing COVID and other nasty bugs like MRSA. We've been also trialing drone deliveries of medication. This is a trial that we completed at Barack Obama Plaza in Tipperary, and it proved to be very effective. So just to summarize, the NHS published an excellent report, the Innovation Lottery, talking about upgrading the spread of innovation in the NHS. What they found, the key barriers to innovation were a risk-adverse culture, the complexity of the NHS, and in our case, the complexity of the HSE, and the lack of funding. But what we have found, that necessity is the mother of invention, and a lot of the barriers that were there preventing innovation in terms of not invented here syndrome were significantly dropped, and we've been able to have some good success with the digital innovation across the HSE network. Eric Topol, he's a renowned cardiologist. He says, while medicine is remarkably resistant to change, the ability to digitize any individual's biology, physiology, and anatomy, along with other elements, will undoubtedly transform the future of medicine. So we've just started on this journey to digitize healthcare. I think we'll quickly catch up on other industries in the deployment of digital in healthcare, but it's long overdue. But you know, every cloud has a silver lining, and COVID-19 has been a big driver, a big catalyst of digital innovation across the HSE. So let me stop there and see if there are any questions. I'll hand you back to Professor Conway.
Thanks very much, Martin. It's fascinating the range and breadth of change that has taken place in such a short period of time. A key theme, I'll just say first of all that there is opportunities for questions for Martin through the Q&A tab at the bottom of your screen. So please feel free to post any questions there. Martin, I will start with a question, and you actually finished off on what was my question, and it's around, as you mentioned, crisis does bring opportunity. And I know that Topol talks about resistance to change. How much did resistance to change feature in relation to introducing such a wide-reaching changes? And I think if we think of resistance, it could come from within, so resistance among staff to the adoption or introduction of digital services and so on, or even openness or resistance maybe from the public in terms of adopting these services, particularly among the elderly.
Yeah, well, there's very, very strong resistance. I think Eric Topol, you know, calls it as it is, that there is very strong resistance to change. And you know, we had to resort to guerrilla tactics to actually get some of the solutions implemented. So rather than look for permission, we sought forgiveness. So we had to move, you know, very quickly. And frankly, we had deployed, you know, the remote COVID monitoring solution at 30 hospitals, and it was being prescribed before most of the mainstream HSE realized what had happened. But, you know, if we had gone through the traditional route, we would still be waiting on it. So we had put in some lightweight governance that allowed us to fast track solution, and that served us well. We have found actually the public to be very open to adopting digital technology. So the issue isn't really with the patients, it's the resistance is in a culture within the HSE that is resistance to change. And it's such an unwieldy organization. You know, the left hand doesn't know what the right hand does. So, you know, the way we have got the innovations across the line is to actually put them in place using agile methods, and then the benefits speak for themselves. And then people, once they see the benefits, they say, okay, yeah, we want more of this, and are supportive.
Thanks, Martin. Yeah, and hopefully the benefits, you know, the enhancements to coordination maybe across the various parts of the health service will eventually realize lots of benefits that staff and users will be able to see that will outweigh any resistance there. I have a question here from Trevor. How do you benchmark against other countries in terms of health digital transformation?
Well, the OECD have done a benchmark in their report, Healthcare in the 21st Century, and we don't benchmark very well. We actually are doing, you know, quite good in primary care, and that's because there's actually one dominant player, not Fitzwilliam, their name will come to me in a second, Clanwilliam, and, you know, almost every GP surgery is digitized and documented, so we're on a par with the rest of Europe. But across our acute and primary care settings, we are absolutely laggard in Europe. Now we're going to look and see if we can do some more detailed, benchmarking, and the OECD will be one of the coordinating organizations. We'll do that. But suffice to say, we don't benchmark well. We have a lot of improvement to do, but I'm pleased to say our response to COVID-19 has been very positive, and we are collaborating with NHSX, which is the digital transformation function of the NHS, and they have said to us, we're significantly ahead of them in terms of the adoption of remote management technologies for the COVID-19 crisis. So I think we're making good progress.
A good start, yeah. Another question from Owen Martin is the creation of an electronic health database for every person in Ireland on the agenda of the HSE? And if so, what are the main barriers to creating this data?
Yeah, it's very much on the agenda. I would be very frustrated with the progress that the HSE has made in terms of implementing electronic health record. The strategy kind of has been, it still needs work and funding of it deeper. Sort of rejected a request to fund the EHR strategy. So the problems lie somewhere between the Department of Health and the Department of Public Expenditure and Reform. We do have a living lab in Cork where we have over 3,000 older patients being monitored and managed using an electronic shared care record. And that's proving very effective. But we have been thwarted in deploying that more broadly. And it's a big area that we're trying to push because, if we can do this for older persons, we could deploy it nationally for all other patients.
Thanks, Martin. Another question from Charlotte. Is there any will from the EU to fund those digital health changes and allow countries to work together?
Absolutely. And the European Investment Bank has made a loan to Ireland, I think over 200 million euros to actually deploy the electronic health records. So there is an agreement from EIB to fund that. But despite that, the deeper and to a lesser extent the Department of Health aren't willing to proceed with that investment.
Okay.
Which is disappointing.
It is disappointing, of course. Another question from Doyen. How open is the HSE to advancing further with e-prescription in the advent of this policy shift?
Yeah, I think we'd like to move. E-prescribing is a very high priority, but again, due to vested interests and an inability within the HSE to execute, it has been delayed. It's a clear priority of Sláinte Care. So I do expect to see movement in the next 1 to 2 years on electronic prescribing.
Thanks, Martin. And another one from Trevor, and it's relating to blockchain. Can Martin see any aspects where it could be integrated?
Certainly, and particularly with the electronic health record, there is significant opportunity there, I think, to deploy blockchain. We had explored a DTIF with the Cedar Centre at UCD around the use of blockchain for electronic health records, but we didn't move forward to that. And what I would say to the folks on the call, as I was saying to Professor Conway earlier, we'd be very keen to explore with DCU the creation of a living lab where we could explore some aspect, and it could be, for example, exploring the use of blockchain for electronic health records. That might be a fruitful area for research, for joint research.
We'd very much welcome that opportunity, Martin. Okay, moving on, another question. Is there a high risk in relation to misdiagnosis? For example, an increase in antibiotic resistance as a result of online doctor visits?
Well, that's more a question for the clinicians. We do a lot of work with Nua Health to They run Web Doctor, and what they see is huge volume now of video consultations, and also we've seen that with the other system, Wellola, because the doctor isn't able to actually read the vital signs. There can be, there's more information that would be helpful to the doctor. And what we've seen is where the doctor has a concern, he schedules a face-to-face appointment. But more and more, we will see remote patient solutions. So, I have a €50 watch that will read it'll read my pulse. It'll also do a blood pressure estimate, and it'll also do my oxygen saturation level. So there's a lot of devices that will become commonplace, and the doctor will actually be able to read vital signs from the patient remotely. So the more we see of this, the more, a virtual environment or virtual consultation will be as good as a physical consultation.
It's really transformative in terms of what it can do, and the benefits that it could bring. I'd like to send a very warm thank you to Martin. I'm getting lots of positive feedback here in relation to how good his presentation was.